Okay. So we know stroke is defined as an abrupt onset of neurological deficit attributable to a focal vascular cause. And we'll see why the idea of an abrupt onset is important in differentiating stroke and other stroke mimics. And we know the different types of stroke. So the risk factors of stroke, we know the common risk factors, the modifiable and non-modifiable risk factors. And the modifiable risk factors, hypertension, diabetes, smoking, things that we can change. But the non-modifiable, age, prior history of stroke, family history of stroke, being male, and other cardiovascular illnesses.
You can change that also.
Sorry?
Being male.
Oh, being male, you change. Oh yeah, that's non-modifiable.
No, I'm saying.
You can change your gender.
Oh, you can. Oh, yes, true. Yeah. So.
Sorry. What did you say?
So there is gender and sex, so you can change one but not the other according to the.
Okay.
Yes, that's a debate. So we have the two main pathophysiology or causes of stroke, how stroke happens. It can either happen as a thromboembolism, where you have a thrombus forming in the cerebral vessels, or you can have an emboli from any other source, like a cardiac source, going into the brain. And most of this is atrial fibrillation, when you have a PFO, where you get a paradoxical, or when you also have a thrombus in the heart. And we're going to see, apart from this, there are other uncommon causes of stroke. And we'll just go through a brief pathophysiology, apart from the thromboembolism and the cardioembolism. So we have other uncommon causes of stroke. We have some genetic causes like CADASIL, Fabry's disease. We have vasculopathies and vasculitis, and we're going to go through some cases and how that may happen. We've talked about cardioembolic causes, and we'll also talk about infections like CNS infections, HIV, TB, meningitis, and other conditions like sickle cell disease. So, Jamila?
A 57-year-old man was admitted with right arm weakness and numbness on the background of intermittent headaches. On examination, he was found to have mildly decreased sensation. Power was 4 out of 5 on the right side. He had dyspraxia in the right hand and was unable to spell his name. His speech was hesitant, and he had left-sided visual field impairment, as well as some photophobia.
Okay, so that is an MRI scan. I'll just point out what it shows, and we're going to. So we have this infarct over here. We have another infarct at the occipital lobe over here. So we have multi-territory infarcts and what was described as blood in the ventricles. Right? So we have both mixed blood and infarct, hemorrhage and infarctive, what you'd call a stroke in this patient, 57-year-old. So what are you thinking about? No risk factors in this patient. It's related to some of the risk factors that we've mentioned. I've given it out. Okay, sorry, people. So the whole idea.
Okay, I was thinking I was thinking two things. Could it have been infarction with hemorrhagic transformation, or was it something like the inherited either CADASIL or something of that sort, since he has no risk factors?
Okay, so the first point, infarct with hemorrhagic transformation, that you'd expect within the infarct, but not, these are different territories, and also just like hemorrhage in the ventricles. So this was just a case that picked to show that you may have no risk factors really of the common risk factors, the modifiable, non-modifiable that we've talked about, but you can present as a case of vasculitis and stroke. And this patient had a biopsy that confirmed primary meningitis of the brain and was treated with steroids and immunosuppressants. And this is just a brief, cause of vasculitis. And the last point is most important. If you have cerebral ischemia that affects different territories and that is distributed over time, and when you do a biopsy, then it's associated with inflammatory changes, then you may think of vasculitis. And what mainly you see in the MRI, you'll see these changes in the subcortical white matter. And I think when you speak about stroke, we'll see what that means. And deep gray matter, deep white matter, and cerebral cortex. So they really don't follow a particular pattern. You can do an angiogram where you'll see this beading pattern, especially in the vasculitides, and they say brain biopsy is the gold standard of this. I'm not sure how often we do, but histologically you'll see this lymphocytic inflammatory process going on. Okay. So we have another case still under risk factors.
Just to say that it's pretty rare. Yeah.
Yeah, pretty rare.
So true, it's a nice illustration of a rare cause, but it's pretty rare. Even when you do get vasculitis affecting the brain, it's often more likely to be secondary to something else. So the last patient we had was rheumatoid arthritis related, possible vasculitis. We didn't do a brain biopsy because the primary team refused, but otherwise so that's an example. So we, or lupus, or other kind of underlying kind of
like right now we have a patient with TB.
Yeah, TB-related vasculitis is actually very common. It's probably more common than even the things that I mentioned. So it's relatively uncommon to get primary angioitis. It doesn't demonstrate.
It's pretty okay. Okay, that's for that. Joe?
13-year-old African American male with sickle cell anemia or disease, HBSS, no prior strokes, presented to the emergency department with dysphagia for 1 week. The evaluation revealed a right lower facial group and dysarthria consisted with the parts of the left hemisphere.
Okay. So, do you want to say what you see?
But yeah, so there are hyperintensities bilaterally.
The basal ganglia?
The basal ganglia, also in the anterior, I think the white gray matter junction.
So the one is actually not in the basal ganglia, it's in the frontal.
The posterior?
The posterior one is capsular thalamic.
So there are multiple small infarcts that are flaring.
Actually, it's not even capsular thalamic, it's higher, it's a higher plane. So these are all subcortical white matter.
So they are multiple and they are bilateral. So it's suggestive of a cause that is not restricted to one territory or one specific country.
Yeah.
And I think in the setting of this history, when you think of vasculitic complication of sickle cell anemia, but without, or also 38-year-old young, relatively young, you still think of cardio-embolic source, given that it is bilateral.
Well, so this is a case, rightfully, the risk factor that was identified in this patient, young, and after all cardiovascular evaluation was actually just the sickle cell disease. And how this happens is sickle cell disease is causes these increased red cell adhesions and causes oxidative injury of the vessel wall, causing inflammation, and hence increased activity of the coagulation cascade. So it's basically hypervascular hyperviscosity syndrome. The same way it causes pain crisis elsewhere will cause crisis in the brain. And how you manage these patients is just regular blood transfusion. If they come in such a crisis or stroke, you'd want to do exchange transfusion in these patients, which also causes secondary stroke prevention. And hydroxyurea therapy for secondary stroke prevention. So, and they say as much as 24% of patients with sickle cell disease will actually have a stroke by the age of 45 years. So it's something important to pick up. And they get these micro-infarcts, these silent strokes that you may not actually pick. But if a patient comes in with this severe headache, non-specific symptoms, then you'd think of a silent stroke and do an MRI in this patient.
So most of these patients actually have quite marked territorial strokes, with the often large artery strokes. And actually the stroke incidence is much higher in children than in adults.
Yeah.
In adults it happens, we see it, but it's not that common. Most of the patients who are predisposed to stroke will get it as in childhood. And actually if you look at all these studies that have been done in the sickle cell disease sector, they've been done in children, with hypertransfusion, exchange transfusion, hydroxyurea, all the things that you talked about. So mostly it's stroke in a child, but occasionally you'll see an adult. And occasionally you'll see an adult with other hemoglobin and the sickle cell trait coming in with a stroke. So even sickle cell trait and certain situations can predispose you to an increased stroke risk. So I have one patient with hemoglobin D disease, for example, who had a stroke. So you can get other hemoglobinopathies also.
So in this patient, there is no benefit of thrombolysis if they present within the window. Because the mechanism.
So the truth of the matter is we don't know is the answer. I'm not aware of any, but I think if they were to come within the window, I think I'll go ahead and from mice or from back to mice, depending on this thing. The bigger question is there a benefit of long-term aspirin? That is an even bigger question because we don't really know whether there's benefit of aspirin in these patients. Did you come across anything about aspirin?
So what I found is that these patients present with these micro strokes such that when they actually present, it will be either a long-standing form of symptoms, like our patient who came with dysphagia for a week, but where they present acutely and you think that this is an actual stroke, then you can give them the benefit of thrombolizing.
No, aspirin.
Oh, aspirin? No. The only thing I found in beneficial in sickle cell is just hydroxyurea exchange transfusion. Yeah, and probably autologous stem cell transplant in these patients.
So, Carol, do you have like a target HB or so the transfusion? I get the concept is to get rid of
the
as much of the
sickle cell
HBS and have as much HBA. So what's like the protocol you give them for how long? Once they get the stroke.
Okay, so once they get the stroke, that's like a vaso-occlusive crisis. So you want to do the exchange transfusion at the time. And what they say is regular exchange transfusions. How often, I'm not sure.
Regular hypertransfusions actually. So you try and maintain them, so keep the HBS, I think less than 40% or something like that, if I'm not 30%.
And then also your target total HB should be below 10, because most of them are usually chronic anemic. So you target your HB to 8 to 10, and then you target your HBS to be below 30%. Yeah, and that's been shown to reduce most of the vaso-occlusive episodes, including stroke.
But the risk of? What's the main risk besides transfusion risk? It's iron overload. Yes. So then you have to now think about chelating agents and things like that. So that is the problem. And sorry, one question. Do these many patients benefit from autologous bone marrow transplant? So
do what?
Do they do autologous or do they?
Yes. I saw much related hematopoietic stem cell transplant.
So it's not autologous, because their stem cells have the
Already,
problem,
yes.
so you can't use autologous, so you have to use related. And obviously not disease, not trait, not disease, that kind of thing.
Okay. Salim?
57-year-old Chinese male presents to the ED with complaints of left upper and lower limb weakness with left facial group and slurred speech. He has any history of similar events. He has a long history of HIV for 4 years. He is a non-smoker. There is no family history of stroke.
So, that examination revealed dysarthria with the left facial droop and left pronated drift. So that was our MRI. What do you say? A CT scan, sorry.
This is a diffusion rate.
Yeah, sorry, MRI.
So it looks like it's like at the watershed area, junction of the AC and MCA.
MCA.
But it's one side.
It's actually, the basal ganglia, insular cortex, and the associated frontal and temporal lobe.
Okay, sorry. The MRI. So the only risk factor that was identified in this patient was the HIV. So also a risk factor. And how HIV causes stroke, it's multifactorial. One, the vasculopathy or the vasculopathy that actually happens with HIV, and may cause the direct inflammation of the blood vessels, may cause increased aneurysmal formation just because of the vasculitis that happens, and also other small vessel diseases that happen in the presence of HIV. You have these opportunistic infections that happen, especially TB meningitis, and we'll just go through about how TB meningitis may predispose one to getting a stroke, and also some neoplasias. We've talked about cardioembolism, which is common in HIV, especially in the aspect of endocarditis, and other coagulopathies in this patient. So in a patient who's HIV with the symptoms, that may be the risk factor. The treatment basically is control their HIV and just the normal stroke management treatment.
Anaplastic infection, CMV is becoming a big cause of vasculopathy. But I think we've had 2 patients in the last 1 year with specific CMV vasculopathy.
Okay. So TBM and stroke.
Another thing is I mean, since highly active antiretroviral therapy came in, it's how long now?
Since 1980, almost
1996,
40 years.
Yeah. So HIV was first described, the first patient was described in 81. Yeah. The first patient in Kenya was described in 83, 84. But you know, highly active antiretroviral therapy actually started in 96. But then by the time it got rolled out throughout the world, it was after the 2000 Durban conference, 2002 Durban conference. So we have a large population, over 20 years now, people in the West, and a large population of over 15 years now, people in Africa, certainly from 2006, so over 12 years, which has been exposed to antiretroviral therapy, some of which was quite atherogenic. Yeah? And there is some evidence for accelerated inflammatory driven, accelerated ectogenesis. So, and you mentioned that in one of your bullet points. So actually we are now seeing that. I don't know if you've seen MIs in people with HIV. You've seen these strokes obviously in people with HIV. And I see a number of patients who have dyslipidemia in HIV. So a large proportion of what we expect to have happen is, and if you know Professor Yonga's, a lot of his research is actually in that gray area between HIV and cardiovascular disease.
Thank you. So TBM and strokes. So most of these strokes in TBM are actually multiple. You'll find them as bilateral and located in the basal ganglia, what they term as the tubercular zone, and this comprises of the caudate, anterior thalamus, anterior limb and genu of the internal capsule, and I'll show you a diagram of that. And you may also have cortical strokes in these patients as much as you have that, and they involve mainly the proximal portion of the middle MCA, ACA, and PCA arteries in these patients. And the mechanism of action is TB in itself is an inflammatory condition, basically, where you have increased production of cytokines, your TNF-alphas, VGF, and matrix metalloproteinase, and this direct damage to the blood-brain barrier. And these attract leukocytes, and there's release of vasoactive peptides in this patient, and this cause a prothrombotic state, and they cause TB meningitis. So this is a diagram I found, which was quite interesting, that someone came up, like if you have strokes around this area, most likely than not, and you have TB, then they term this as like the TB or tubercular zone. It may not be true, but it's something to help. But if you have like in the larger areas, your MCA, your ACA, your PCA territory, then you think there's more of what they call ischemic zone. And this is just DWI, showing restricted diffusion in the right caudate nucleus, both thalami, lentiform, where they term it as TB tubercular zones. And so it's something to think about if a patient comes. You think actively treat their TB meningitis. Then the role of steroids, and this is where the role of steroids versus in such patients who have TB, what we call TB stroke. Yeah, so it's not really, we treat TB meningitis with steroids in essence, but there's no shown benefit in stroke treatment. So it's just basically stroke therapy in these patients with TB and actively treat their TB meningitis.
So would you give them aspirin?
I think you would in these patients. I don't know.
It's controversial as far as I know. Yeah. Because the pathogenesis of this is the vasculitis, so you just treat the TB and give them steroids. Yeah, at the moment, as far as I know.
Okay.
You could sometimes choose to give steroids, especially when they are kind of atypical in terms of not in that area.
Okay.
Especially the edema. But would you give aspirin? Because I've been
The steroids I would certainly give.
Aspirin.
That's what I was saying. Aspirin is controversial.
Yeah. Do you give
Those are people that showed evidence.
If the main presentation is from the stroke rather than from the TB meningitis, I would consider it. Yeah, because maybe there are two things going on. Yeah. But if the main presentation is from the TB meningitis, I would just crack on with the TB treatment.
And maybe they have other comorbids, hypertension.
Those are people that show some evidence for aspirin use in patients presenting with strokes as a result of tuberculosis. The only evidence was that you're worried about secondary prevention.
Yes.
But it only prevented recurrent strokes in this patient with TB in the first 3 months.
Yeah.
So beyond 3 months, there was no conclusive evidence.
But that's true for aspirin and stroke actually. The long-term benefit is less than 1%, but it's actually 9 out of 1,000. But the initial benefit is almost 50%.
The initial month.
Yeah.
Okay. Abu?
A 75-year-old woman is evaluated for a 16-minute episode of right arm weakness and dysarthria. The symptoms have not recurred. She has hypertension and type 2 diabetes mellitus. Medications are aspirin, metoprolol, enalapril, and metformin. On physical examination, blood pressure is 156 over 94 millimeters of mercury with a pulse rate of 62 beats per minute and regular. The respiratory rate is 60 beats per minute. No carotid bleeds are noted. Neurological examination findings are normal. Results of laboratory studies obtained 3 weeks ago show a hemoglobin A1C value of 7.1% and a serum LDL cholesterol level of 68 milligrams per deciliter. She has a stroke.
60-minute episode that has resolved.
Oh, it's resolved. TIA.
So we'll go through TIA, which is interesting. So a syndrome, TIA is basically a syndrome characterized by sudden onset of a focal neurological deficit presumed to be of a vascular basis without acute infarction. So note the 24 hours for TIA that we were giving has been phased out. And so it's basically sudden onset that results without an acute infarction. So there's this risk stratification for TIA based on this ABCD2 score, and to just show where you have a 2-day risk for stroke in these patients, and also
one thing that if the episode lasts for more than a few minutes, then it's often a stroke. So if you do a diffusion weighted image, you'll probably find evidence of a stroke. And if you don't find it the first time, then if you do a deferred image, so let's say 48 hours later, then you may still find evidence of a stroke. So the longer it is, the more likely that you'll find a stroke. And so long as you have a diffusion deficit, then it's a stroke, not a TIA. But essentially, in terms of treatment, it's the same, isn't it?
It's basically the same. It's basically antiplatelet therapy.
So in that case, you couldn't have called it a TIA as yet.
You could say the presentation is of a TIA,
yeah.
but then you revise the diagnosis as soon as you have it.
Yeah, and it's right. They say most TIA symptoms actually resolve within 60 minutes in these patients. So like Dr. Hooker has mentioned, what we do is we do an early diffusion weighted image. And if you find, and this is just a study that showed patients who had symptoms within 1 hour, that resolved within an hour and also after 1 hour. And they wanted to see how many of these patients actually had a positive early DWI versus changes in the diffusion weighted image in these patients. And so if you do a stroke, an MRI DWI, when the patient presents and there are no actual features of acute infarction, then you'd call it a TIA. But then when you perform it hours later and you actually see acute infarction, then you need to revise your diagnosis in this patient. So the management...
Sorry, go back to the ABCDs, please. Vectors,
yeah. There. Okay. Oh, so this is this is basically risk stratification to actually show you your risk for stroke after a TIA has happened, and then you'd manage it actively as a stroke, and also your recurrence within 90 days. So your age above 60 years, that will give 1 point. Your blood pressure will above 140/80, so hypertension basically. If you have clinical features, if you have unilateral weakness, then you'd give it a 2. And if you have speech impairment without weakness, that's a 1. If you have duration of symptoms less than 1 hour, that's 1, and more than 1 hour, that's 2. And if you have diabetes, that's 1. And then there's this with the image plus the image. If you have, so the score is 7, and the image you'll give it a 3. You know, if you have acute infarction on DWI, that's a high risk already. So it shows you that you have a risk of actually getting a stroke and also a recurrence within 90 days. And so you to be more aggressive in this patient. Yeah.
But if you have an acute infarction, it's already a stroke.
It is a TIA.
Yeah. And then that score risk, unless Dr. Oka would correct me, it just helps you to know who to manage. We used to see as an outpatient and who to manage as an inpatient. But would you really manage them as outpatients?
I don't think in this day and age it is fair to do that, except if you have a rapid TIA service. So there are hospitals which have a rapid TIA service, walk in anytime, and certainly within office hours, but some of them have a 24-hour service. You just walk in. If you have a TIA, then you are rapidly triaged, and those who are very high risk are admitted, the others are immediately started on secondary prevention, and the investigations are being done within the next 24 to 48 hours. Except if you have that, I think it's safer to admit this patient. So the last TIA patient we had last week, ABCD2 score was 2. But she had so within 24 hours of admission, she had multiple, like a flurry of TIAs. Indeed, if we're talking to her and she would have a TIA for a few seconds, for a few minutes, and then it would come back, you know, all speech, yeah? And we scanned her again, there's no stroke. So, you know, then everything settled eventually on dual antiplatelet. So just to give an example, in fact, if you have a low score, doesn't mean that.
Because traditionally they used to say 0 to 3 is outpatient and then above 4 you manage. But where I train, they have a TIA clinic where patients are seen. There's someone who sits in the clinic and they come in every 6 hours. So that would work there. But here we lose our patients to follow up, especially when they think they have a TIA. If you tell them they have a mini stroke, you just lose them to follow up. They don't come back. So it's better to just admit them just to be safe and work them up.
Okay. So, treatment is basically antiplatelet therapy, and there's this chance trial that they done in China that showed they were looking at clopidogrel in high-risk patients with acute non-disabling cerebrovascular events. And basically what they showed that there was a benefit in giving dual antiplatelet therapy, this is clopidogrel and aspirin for patients with stroke, for at least 21 days, and then clopi alone to 90 days, for at least 90 days in these patients, versus aspirin alone. So there was benefit in giving the dual antiplatelet therapy, and I think we should take this up as our protocol in TIA patients. So there's some risk factors that actually may tell you that this patient after a TIA will progress into a stroke, and it's basically what we talked about, the ABCD2 score. That is, but also of note, if you have any intracranial stenosis or extracranial stenosis or occlusion when you do your CT angiogram, then these patients are at a high risk of progressing into a stroke, these patients. So we'll go a bit first. Sorry?
35-year-old right-handed female with a history of headaches presented with left-sided weakness preceded by numbness. She reports that she first felt numb on the left hand and that went up to involve the arm, shoulder, trunk, and left leg, then had weakness in the above territories. Capillary blood sugar in the ambulance was 1.8, successfully treated with IV dextrose. Neurological examination revealed residual left arm weakness, power grade 3/5. By the time of arrival in the emergency unit with a normal brain CT.
What are your differentials here?
Hypoglycemia.
Mm-hmm.
I don't know if that can cause a, I think so.
Mm-hmm.
A stroke, well, not a stroke, but
Stroke mimic.
Stroke mimic, yeah.
Yeah, a stroke mimic. What would you think about? Remember, we defined a stroke as an abrupt onset of
this is,
symptoms.
This is not really abrupt. It starts at one point. She also has headaches, so that's another thing to think about. Migraines with like an aura or even.
Yeah. So you're right. So this was a hemiplegic migraine in these patients. Just of note, history of headache. She may not really say that she had a migraine, but also the reporter, they present with these numbness features that actually starts from the hand, may start from the hand, and then they can literally tell you that it went down, and then may have some residual weakness. Always think of a headache, but also the hypoglycemic episode that she may have had, could that have contributed? But then she had some bit of residual weakness on arrival. So those are our two differentials in these patients.
So how would you image this patient?
So you actually do an MRI scan for this patient, and you look at your stroke MRI protocol. So you want your diffusion weighted image, to see. So a brain CT scan really will not show us much. Yeah.
Because if this patient did have a stroke, then you would be forced to kind of consider treating it as a stroke. And once in a while you get what is called a progressing stroke. So a stroke that stutters, or a stuttering stroke. So instead of bang, you get one thing and then it picks another. So it's like the infarction is spreading. You see, so you can get a presentation that is not completely typical of an abrupt onset stroke. So I agree with you that, and this is a patient who deserves an MRI. But yeah, I mean, in this situation, if she's never had an episode like this before, and this is the first time, and she has a low blood sugar, then I would not make a diagnosis of hemiplegic migraine. I would ascribe the symptoms to the hypoglycemia. But then this is not a patient. It's not a patient with diabetes or on insulin. Then I have to find out why this patient has become hypoglycemic. So it may be that she has an insulinoma, or she has some other underlying cause. Maybe she's got Addison's or something going on that is causing her. Yeah. So just to get that, you always think about the patient kind of holistically rather than.
Thank you for that. Karishma?
65-year-old right-handed man complained of difficulty speaking and visual disturbance on the right side, lasting for less than an hour. Neurologic examination in hospital showed a right homonymous hemianopia, right-sided inattention and right-sided weakness. Before the onset of symptoms, there had been a 5-minute episode of muscle twitching affecting the right face and body, after which his symptoms worsened before fully resolving over the next 24 hours. Brain MRI showed an old left hemisphere cortical and lacunar infarctions. What are the differentials?
What would you be thinking about here?
So initially when he came in with difficulty speaking and visual disturbance, I was thinking of, and he has a right homonymous hemianopia. Posterior circulation strokes can give you that. But the right-sided inattention, you will have to have something in the parietal, the non-dominant parietal lobe, right-sided weakness. But if there was a 5-minute episode of muscle twitching, I'm thinking, could this have been a seizure and then they got like Todd's paralysis after?
Yeah, so this was basically rightfully said, and the case was trying to bring out the fact that Todd's paralysis, where you may have weakness following a seizure in this patient, so look out for that. But also the note of old hemisphere lacunar infarctions could just be an epileptic focus in this patient. So it was something to look at. So in this,
Just going back to this patient. I mean, so some of these patients' deficits were probably fixed from it's unlikely that everything would reverse. So it's probable that homonymous myopia, so that to get inattention on the right side with the left sided thing is less common. Yeah, usually it's the other way around. The right-sided focus causing left-sided inattention. Yeah. So it's a bit less. Yeah, less. It can happen. Less likely. Yeah.
Okay. So basically, you're talking about TIA and mimics, and we have several mimics of TIA, and I'll just move to this because of time. And a meta-analysis was done about the 20 most common stroke mimics, and we see seizures come out high, syncope in these patients, other sepsis in this patient, other causes like brain tumor. Basically, when you get a stroke or a TIA mimic, like Dr. Sylvia said, always work them up. It may just not be a TIA or a stroke. It may be an underlying condition that they may have. So always get this have this in mind. And I've attached a table to just see are there things that you can differentiate TIA and mimics. If they are younger age history of seizures, then you think of a Todd's paralysis. If they have the negative symptoms versus the positive symptoms. So the positive symptoms is things like spreading onset, things like seizures, then you'd think of a mimic after you've ruled out a TIA, as opposed to negative symptoms where you actually have either loss of movement or loss of power on one side. Timing, also important, abrupt onset versus now a progressive onset. You think syncope tends to last around seconds to less than a minute. And also, do they have associated symptoms? Do they have tongue biting with that? Then you think of mimics. We have what we call stroke chameleons, where strokes actually imitate other diseases due to their tempo of onset. And here we'll just do one case. I'll just read. This is a 75-year-old presented to the ED with a history of dizziness, vertigo, and vomiting. And she had a history of sick sinus syndrome with a pacemaker and also Meniere's disease. And on examination, she had AFib, ataxic gait, nystagmus, and marked unsteadiness in this patient. So this patient was initially diagnosed with Meniere's disease, her history, and also these features of vertigo. And she was prescribed that and was actually discharged home. But however, the symptoms and signs of lack of improvement with these suppressants, actually the neurologist organized a brain CT scan which showed a subacute left cerebellar hemisphere infarction. So they called it a vertigo chameleon. So symptoms that suggest other conditions, but they actually present with a stroke. They're actually a stroke. I'll just move forward to this case.
So I think that case was very nice because, I mean, if you get a monoplegia, it's very difficult to work out where the lesion is. Yeah, very difficult. So that's the kind of patient you need some meticulous exam and also sometimes in history, and also sometimes just to investigate them just very, very broadly.
Okay.
Actually, dizziness, I get a dizzy patient, I get very agitated. We've had quite a number of dizzy patients who've been missed and gone home, and later you find they have a serious accumulation stroke. Especially if the dizziness comes smack bang, and you find that it's persistent, it's not going away. And maybe the patient has other risk factors, they're diabetic, they're hypertensive. It's very important to be careful with such patients, just rather than label them as BPPV.
So
that's fine.
this is a case of the monoplegia, so we'll continue with that. I'll send these slides to you so you can go through the cases. So stroke now, our actual diagnosis. So once you get a patient with a stroke, then you'd want to once call them and then evaluate them and then treat them. And now that's what we're going. So we all know about the NIHSS score. We have it, and I think most of us have taken the training. And all patients who come in with a stroke, and I think doing my audit is very few of us actually do NIHSS score for patients who are not being thrombolized. We do very well for patients who are thrombolized, but we don't do for other patients, which is important because then it tells us our stroke severity and also complications for these patients. So how do we diagnose stroke? And I think as we talked about the TIA and the mimics, we say, so our recommendation for imaging is a non-contrast enhanced CT scan for all patients who come in, especially who come in within 4.5 hours. Then we'd want to do that CT scan. And this is recommended before fibrinolysis administration in these patients. Then there is a role of doing MRI, especially diffusion weighted image MRI, a quick MRI if you want to be clear about these patients, especially for patients who have a wake-up stroke and it's not clear at what point did they have the stroke. So these are just some images that I want to point out. You can see the dense, the thrombus in the MCA region in these patients. So this is the thrombus in the MCA, the dense MCA sign that we see. These are actually mentioned as a right posterior cerebral artery thrombus in here. And then now there's other thrombus in this patient. So basically looking out for thrombus, especially if they're within the 4.5 hours, and trying to treat it, and also it will guide your thrombectomy management in this patient. And this is just an MRI of the different modalities of MRI. This is showing a thrombus in this artery, but also just progression of this is a diffusion weighted image of a stroke where you see early stroke changes in this patient. So other tests that you'd actually do for all patients who come in, you need to do a blood glucose for them. And we'll say the importance is hyperglycemia has actually been associated with a poorer prognosis than hypoglycemia. So if they have a glucose above 18, then you need to give them an insulin infusion and lower their sugar to between 14 to 18. If they have hypoglycemia, then you treat. All patients should get an ECG in this patient, and then for patients who are on anticoagulation, then we do an INR. But also for all patients should have.
If you have hyperglycemia, lower to what?
To 14 to 18. That's what I got. Millimoles.
That's still high.
Okay. So what I found is that anything above 18, the risk of worsening the stroke is actually high. So I think then in our setup we do 7 to 10.
If you're thrombolizing, I think the idea is to bring it lower because the risk of bleeding is high in people with hyperglycemic. If I'm not mistaken, just check that.
Okay.
I know for
that. I have it here.
You target 10.
Yeah.
The target is usually 10.
So I think it's, if I'm not mistaken, I think it's around there also for patients who are to be thrombolized. It's not on that thing. But
yeah.
Yeah.
Okay.
Caroway troponin.
So most of the times the troponin will be high, but there also the thought was that there may be a concomitant myocardial infarction in these patients, but we know that most times the troponin will be high because you already have a thrombus in the brain. But if it is high, then you should trend it and see. And I think we have had...
The troponin is not because of the thrombus. The troponin is because of myocardial injury. So the stroke-associated myocardial injury, which can raise troponin without causing a myocardial infarction. But there is also the possibility that that stroke is actually secondary to a myocardial infarction. So you may actually have a patient who had a myocardial infarct, silent, and then has a stroke. Yeah? So that's the reason for doing the troponin. The third thing is that it's been shown that even in patients who do not necessarily have a myocardial infarction, raised troponin portends a poorer prognosis in patients with stroke.
Okay. So there's the supportive care, and here in essence I wanted to bring out the aspect of blood pressure monitoring. So for patients who are undergoing thrombolysis, then you want the blood pressure to be less than 185 over 110, and then 24 hours you maintain it at less than 180 over 105 in these patients. There are different modalities of how you can lower your blood pressure. What we mainly use here commonly is labetalol, IV over 1 to 2 minutes, and you may repeat to bring about the blood pressure drop in these patients. And after the thrombolysis, then you can transit them to oral medication in this patient. Of note, also their oxygen, maintain their oxygen above 94%. So treatment, so we know therapy that mainstay of management is basically IV thrombolysis, and here we use alteplase 0.9 milligrams per kg, given within 4.5 hours basically, and we aim to have a dot-to-needle time of 60 minutes. Remember, your CT scan, if possible, should be done within 25 minutes of arrival to the therapy. So on the fibrinolysis, there's also there are studies that have actually used tenecteplase or tried to see tenecteplase. Alteplase is the only FDA approved thrombolytic, but also someone used tenecteplase up to 6 hours, and there was no really clear benefit. It's not as effective, if I'd call that, as alteplase. And it was.
I think it's effective with alteplase. The only problem is it's not approved.
It's not approved.
Yeah.
Okay.
It's just not approved.
So if you're stuck, you don't have alteplase.
If you don't have alteplase,
you can use
it. Yeah. I wouldn't have done this until recently, but I remember before people were using tenecteplase and I was a bit uncomfortable, but now I think with the data we have, I think it's
because the advantage for it is like
it's a push.
Push,
So that's what people are looking at to see if we can get approval for this. But at the moment it's not approved. So at the moment the only one that's approved is
Okay, so the study that I saw said it failed to demonstrate superiority, but it was non-inferior to alteplase.
That is true, you're right. It did not show superiority to alteplase in that particular study, but the outcomes were not different, really.
Sorry. Yeah. Okay, and we know the contraindications of thrombolysis in these patients.
Can I ask you something? Mm-hmm. So is the severity of stroke a contraindication?
So they say strokes above more than 1/3 of the MCA territory of the hemisphere, of the MCA territory.
On scanning?
On scanning, yes, okay. That's a contraindication. But on examination, I don't think so.
What about the NIHSS score?
So 20.
25.
I think an NIHSS score of, I don't know, 20.
Is there a contraindication?
They say the relative contraindication for these patients, yeah.
Okay. Okay, so certainly for the 3 to 4.5 hour period, if the NIHSS score is 25 or more, then you would hold back. Yeah. And also in that situation, then if you're more than 80, you'd hold back. Yeah, so between the 3 to 4.5.
So So in conjunction, or because like here, we've had patients above 80.
Yeah.
We've successfully thrombolized.
Oh yeah. But I'm talking about the 3 to 4.5 age. I mean 3 to 4.5 hours window. Then if they're over 80, then you would hold back, and if the NIHS score is very high, then you would hold back, because the chances are they are at higher risk of bleeding. That's the argument, because you are later within that. But I'll talk about that in just finish.
Yeah, okay. 4.5 or above 4.5?
3 to 4. So above 4.5, you can't thrombolize at the moment, but I'll just tell you something about it.
Because they're also talking about here. There was an oral anticoagulation.
So patients,
it's actually there.
3 to 4.5 hours. Patients older than 8 years, those taking oral anticoagulation, and baseline NIHSS of above 25. Or those with both a history of both stroke and diabetes, the effectiveness is not well established.
And the NOACs also, you don't at all for anyone,
you can.
Whether it's 3 or
you
below,
can. So
you
we
can't.
actually this weekend, we had a patient, Dr. Washington's patient. The patient actually had an arrest from massive myocardial infarction, then resuscitated, doing pretty well, then has a stroke, so has a mural thrombus from the myocardial infarct, so he's anticoagulated, and then has a stroke, so on heparin has a stroke. Sad situation. I mean, so I mean, they asked me, can we reverse the heparin and thrombolyze. Obviously, Mugere is not around. Ideal candidate for thrombectomy, this patient, but Mugere is not around. Nobody else can do it. You should learn to do that.
I will.
Yeah. So we couldn't do a thrombectomy, and we could thrombolize, because so I said no. Then I said, ask the Raj what he thinks. The Raj said no as well. So we did, but thankfully the patient actually reversed. He recovered. Yeah.
And we had such a patient, the one who was thrombolized, I think had been on anticoagulation, but was stopped. How many hours before? We're discussing the day before. It was more than 24
no, that
hours.
was the patient I was called. Yeah, well, so the Raj had been called, and then I had been called as well. The Raj couldn't come, so I came actually at night here, around 10:30, and the patient had been on anticoagulation, but there was some suggestion the patient had not received the dose the previous day or that day. So because of that, the patient was thrombolized by the primary team, but then had a massive bleed. Yeah, but things were bad.
Yeah. So for NOACs, is it 24 hours or 48?
24?
They say 24, but
yeah, I think you need to be pretty sure. Yeah, you need to be pretty sure. And then there was some question about renal dysfunction. So initially I'd been told CKD. So CKD in a NOAC CKD, they're always very uncomfortable. So but the patient actually, when we did the creatinine, was normal. So which is just glad.
Maybe it's the family, they were not too sure about the timing.
Okay. So we know the management in NG tube feeding, early speech and language therapy, treatment of other conditions, and early mobilization with physiotherapy in these patients. After thrombolysis,
just one thing about the PEG. What's like the kind of timeline you give? How long do you?
Yeah, so a patient with a severe stroke, at high risk of aspiration, don't feed for the first. You cannot feed for even 3 days. You can keep them off, oral, and then and make decisions thereafter. There is no rush to do a PEG. It's not been shown that a PEG is advantageous over a nasogastric tube. If the patient is showing signs of not recovering from the dysphagia in the first week or so, or has a massive brainstem stroke and it's unlikely to recover, but I think the majority of patients will wait. And even the PEG, in the majority of patients, we are able to reverse them eventually.
So for mechanical thrombectomy in these patients, so they should receive a thrombectomy when, if, and we'll talk about the time limits. Before, they said can be initiated within 6 hours of symptom onset, but now with different studies that have come up, and we'll go through them, you can actually go to 8 to 24 hours has been shown. But if they have a modified Rankin scale of between 0 to 1, if you can see a causative occlusion of the IC or MCA, and if they have an NIHSS score of above 6 and aspects. And I just wanted to bring about the aspects. It's basically a CT score of this patient, and it's quantitative depending on the places of the stroke in these patients. And it's a CT scan mapping, and I think I've described how it is that you do it. And also there's the posterior circulation aspects, and if you have at least these, then you can do thrombectomy of the posterior circulation. So these trials, we'll start with the diffuse 3 trial. They actually saw, because the cutoff was 6 at that point, but they saw, can we do thrombectomy for patients who actually presented between 6 to 16 hours? And they used perfusion core mismatch and a maximum core size as the imaging criteria to select these patients who had an anterior circulation stroke. And they found out that there was actually a benefit in these patients with an MRS score at 90 days in these patients. And then the DAWN trial actually saw, can we push it to 24 hours with several criteria in these patients? And here they also use clinical and imaging mismatch in these patients. So your NIHSS score and your imaging findings on the DWI in this patient. And they also saw 90-day benefit in patients who actually with, and I've included that in my presentation, and I said in specific population of patients. In these patients, then you can offer them thrombectomy at 24 hours of therapy. So the management, basically preventing a secondary stroke, aspirin in these patients, recommended within 24 to 48 hours. And if you've given thrombolysis, then you delay until 24 hours. The dose of aspirin, European guidelines, 300 milligrams for 2 weeks, and then continue with clopidogrel for 75 milligrams. But for patients who get a stroke while on aspirin, then there's benefit to switch them to clopidogrel as an alternative in these patients. So statin therapy, all patients should be started on high intensity statin therapy unless there are contraindications in these patients.
So when we thrombolyze and there are small areas of bleeding, please maintain and we don't give aspirin.
No, it's no contraindication.
There's no contraindication.
Yeah, it's just a symptomatic bleed.
Yeah.
Large bleed. If it's a symptomatic bleed, then you have to hold it.
Okay. So anticoagulation after a stroke.
Are you coming back to this? But I think let you finish because we are running out of time, and then I might say a few.
Okay. So anticoagulation in stroke, if it's a TIA and they have atrial fibrillation, then you start oral anticoagulation 1 day after the event. If they have a mild, moderate stroke, then 3 days, 3, 6, 12, or 4, 6, 12, depending. And they have atrial fibrillation, then you start anticoagulation dependent on the size of the stroke. And
this is the Hans Christoph Diner rule. Just eminence based, there is no evidence behind it, but it's the best we have.
Okay. So anticoagulation for primary prevention. So there's role of newer oral anticoagulation in these patients. So warfarin and also rivaroxaban, or basically everything. Do your CHA2DS2-VASc score and see if they have any score above 12, then they are 2, above 2, they should be on oral anticoagulation. If they have a CHA2DS2-VASc score of 1, then they say it's neither here nor there. If they're at a higher risk, then you can give anticoagulation, but 2 is the cutoff. Note your Hasbled score for patients who have a risk of bleeding, especially on warfarin with these patients. So remember your treatment for acute neurological complications. If the patient has they're at a risk of getting brain edema and especially a large stroke, and they have signs, then you'd go for decompressive surgical evacuation. But also the use, what I've seen here, mostly the use of hypertonic saline and also the use of mannitol in this patient. You can do mechanical ventilation with hyperventilation, but basically if they're at a risk of herniation due to the edema, then decompressive craniotomy in these patients. If they're at a risk of seizures or they have recurrent seizures after a stroke, then you treat them as seizures and give them anti-epileptic drug. There's no role for seizure prophylaxis in these patients. And if they have hydrocephalus, especially with bleeding. So
there's a nice article in Critical Care Journal from Mayo Clinic on management of patients with raised intracranial pressure with a special emphasis on stroke. You can have a look at it. And they outline everything that you probably need to know about this patient. They also used to use cooling, but they say now cooling you have to weigh the benefit vis-a-vis the complications. They are at a risk of hypercoagulability, they can get infections. So you don't really necessarily focus on cooling so much in it.
Okay. So this is article Dr. Hooker sent me. Secondary prevention of stroke with dual antiplatelet therapy with silastazole, which is a phosphodiesterase.
Are you at the end?
Yes, I'm at the
last
end.
one?
Yes, and then the rehabilitation slide.
Okay. So can I take a few minutes to so the things that are changing. So and that have changed. So one is in patients with TIA minus stroke. So immediate secondary prophylaxis or early secondary prophylaxis would be dual antiplatelets rather than single antiplatelets. But all the evidence from the Chan study, from the more recent Point study, so both in Chinese and non-Chinese populations suggests that it's only beneficial early. So dual antiplatelets early, so you can use aspirin and clopidogrel early for 3 weeks, maximum 4 weeks. Beyond that, you're giving dual antiplatelet long term with aspirin and clopidogrel is deleterious because the bleeding risk is greater than the prevention. So early on, dual antiplatelets, and so you can actually load with clopidogrel 300 and give the aspirin and clopidogrel 75 every day thereafter. Yeah. Okay. So that's one thing. The second thing is the issue of thrombolizing in these patients. So there is actually the International Stroke Congress has been going on, conference has been going on, and there have been some papers presented suggesting that you can actually thrombolize wake-up stroke and stroke beyond 4 to 6 hours, so long as there's a diffusion-perfusion mismatch or a clinical perfusion mismatch. Yeah. So looks like it is no longer time is brain, but time the brain. That's actually the phrase that's being used. So you time the brain, you say, okay, does this brain have potential to, is there a penumbra that is recoverable? And then you go ahead and thrombolize. But obviously this is not guideline yet, but this is the way things are going. Yeah. So and the same for thrombectomy. Even the 24-hour cutoff may not be true. It really depends on whether there's a mismatch or not. If there's a mismatch, perhaps there's a role for thrombectomizing this patient. So that's where things are going. Then the longer-term antiplatelet prophylaxis, there is evidence for aspirin, for clopidogrel. I've told you that there is no evidence for dual aspirin and clopidogrel, but there is evidence for aspirin and dipyridamole. Yeah, so dual in that situation, but the risk is higher side effect. Now this study comes in at that point because now we are looking at versus long-term aspirin or clopidogrel alone, and this is now remote prophylaxis, so not immediate prophylaxis, but longer-term prophylaxis. Then you can actually use silastazole together with aspirin or clopidogrel with a reduction in long-term stroke recurrent stroke risk without an increase in bleeding risk. So that's a new development. The only problem is this is a Japanese trial. So the generalizability, but then you could argue even the European trials are the generalized, or American trials are the generalizable to us. So that's one thing. The other thing is people have looked at triple therapy early on, and it's not been shown to be benefit. There's a trial called TRADIS, no benefit, yeah, and increased bleeding risk. So it's not recommended.
So triple therapy is what?
Triple, they used aspirin, clopidogrel, yeah, triple therapy.
And there's one also with rivaroxaban with that.
Yeah, there's a aspirin rivaroxaban trial, but I don't think that was early. That was later on. Yeah, and then there is the whole. Then there is the issue of using other antiplatelets like prasugrel as opposed to yeah. So there are a number of kind of approaches that people are trying to use, and prasugrel was actually similar to clopidogrel in the study, but they had a non-inferiority cutoff. It did not meet the criteria for the non-inferiority. So just to give you where things are heading in terms of
So how do you time the brain? What's the
it's clinical perfusion mismatch, or like she said in the two studies done in diffuse 3, or diffusion perfusion mismatch. And so in our setup, the CT, so we could actually expand the CT protocol, non-enhanced CT scan, CT angio, CT perfusion. If we can do that, then we could actually do that in appropriate patients. We can actually do that here. And I think
rehabilitation. Okay. Thank you, everyone. That's the end of our talk. Thank you, Dr. Mbogo and Mr. Kuka.
So DVT prophylaxis
is important.
Yeah. So what would be the?
So if they're in hospital, pneumatic compressions is actually advised, and then now if they're immobile, then you can give the anticoagulation. Sorry? I think either depending on the stroke 3, 6, 12, like we said.
So no. In this case, we are not talking about anticoagulation. We are talking about, we are not anticoagulating. We are talking about. So that's one thing I've seen in notes. If people talk about anticoagulating, when you actually mean venous thromboembolysis prophylaxis. So it's important not to say anticoagulant, because I saw another patient of mine who was seen by one of you guys, and they said anticoagulant. But it's not anticoagulation. You're actually giving DVT prophylaxis. So when you're doing that, you can actually do that. In a patient whose mobility is poor, you can do that right away, as long as they are, But obviously, if you're thrombolizing the patient, then you wait for 24 hours.
Okay.
Thank you.
It's interesting that